My name is Jong Sunny. I'm going to present palpitation of cardiovascular. JS is 78 years old, an African American male. The company was alone appears to be unreliable historian. His chief complaint is I have palpitation on and off. JS is a 78 years old African American male presenting with a 2 weeks history of intermittent palpitations, which he describes a racing and irregular heartbeat making him feel strange and worn out. The episode occurs both at rest and with the minimal exertion lasts several minutes and have become more frequent in the 5 days. He reports experience accompanying fatigue and lightheadedness with event but denies chest pain, syncope, dyspnea, and diaphoresis. He has no similar history and he has not experienced any non-structural heart disease or change in medications recently. He never had a pre-existing condition of arrhythmia or palpitation. He is worried about the growing incidence of palpitations and severity. Past medical history. Type 2 diabetic diagnosis in 2010 was under control on metformin 1000 milligram the BID. Gout diagnosis in 2015 on the allopurinol 100 milligram daily. Allergies, allergy to sulfur with a mild rash and no environmental food allergies. Medication allopurinol 100 milligram daily, metformin 1000 milligrams daily of BID. Denies alcohol taking history, tobacco, and recreational drug reported, but he drinks 1 cup of coffee daily. Immunization up to date, family history. His mother is still alive, was healthy, and his father that expired in 70, and his maternal grandmother has atrial fibrillation. She died a long time ago. His maternal grandfather has lung cancer, and this is expired a long time ago. Paternal grandparents died a long time ago. Social history. He retired as a warehouse supervisor and completed the high school diploma. And he lives alone on one-story house, gets assisted by his daughter 3 times a week who lives nearby. No sexual activity noted since his wife expired 10 years ago due to stroke. No history of STD. He is Baptist and going to the church every weekend with daughter. Walks 30 minutes a day with the neighbors in the morning. Uses sunscreen, wear a seatbelt, and no fire alarms at home. No sodium, sugar, food, and prepare the meal by himself. And the review of systems. There's fatigue as positive denied any fever, chills, or night gain, or weight gain or loss. Cardiovascular, the population, fatigue, but denies chest pain, and orthopnea, paroxysmal nocturnal dyspnea, or the swelling of the neck. Allergic to sulfur was mild rash and objective. His BMI is 29.2, overweight, and temperature is 98.2, BP is 132/70, heart rate 145, and respiration rate is 18, and oxygen saturation is 96. In room air, the cardiovascular is irregular, increase in heart rate, tachycardia up to 145, S1, S2, variable intense, no audio murmur, nerve rubs, and gallop. Intact systemic, the peripheral pulse, diagnosis test, EKG was done, atrial fibrillation and the rapid ventricular response heart rate 145 and unchanged ST segment without the sign of infarct. Primary diagnosis uncontrolled atrial fibrillation was a rapid ventricular response, and differential diagnosis. Atrial fibrillation was AVR supported by EKG result irregular pulse and palpitation reported by the patient. So supraventricular tachycardia less probable since it does not have a regular rhythm, and rare complex tachycardia is not seen in the EKG. Hyperthyroidism, the atrial fibrillation, it requires some test of thyroid functions not at present justified by the symptom. Tachycardia and palpitation anemia includes not as probable. Consider CBC to exclude electrical imbalance like hypokalemia, hypomagnesia, potential precipitant order to exclude. Plan. Diagnostic plans, the CBC, CMP, TSH, hemoglobin A1C, lipid panel, evaluate the cardiovascular risk factor, imaging test, 12 lead EKG is completed, and consider echocardiogram and imaging, examine the structural heart disease, valvular issue or thrombi, chest X-ray if pulmonary signs develop, and cardiomegaly. Therapeutic plans, the rate controls, the metoprolol succinate 25 mg the PO daily, and the anticoagulant start with apixaban 5 mg BID, considered the CHA2DS2 BASSC score of greater than 3, and teach about the possible bleeding during drug and drug interaction and the necessity to comply the medication. AAV nodal blockers should be avoided, and close monitoring of renal function and during and before anticoagulant. Patient education, so describe the diagnosis of atrial fibrillation and discuss potential complication like a stroke, heart failure, importance of taking medication, lifestyle changing, and monitoring, prevention of fall, emphasize the need to regular follow-up of blood test, medication dosage change, and possible report to cardiologist. And the cardiologist report to review the possible of rhythm control, potential need of echocardiogram and cardioversion. Plan. Follow plan to recheck the vital signs and symptoms at 48 to 72 hours to evaluate response to heart rate control therapy, review the lab result, and reassess the safety of anticoagulation. Range cardiology follow in 1 week, return or contact or send to ER if symptoms get worse or persistent anytime. Thank you for listening.